Well, it's a pleasure to be here, and I see that there's about 90 people listening, and my task is to give you an update on cartilage repair, the state of the art. And when I thought about this talk, I thought most people listening probably don't do cartilage repair. They just want to know where we're at, those of us that live it and breathe it every day. So that's going to be my task today, to try to bring you up to date to 2021. I do have disclosures, but I don't have any intellectual property in cartilage repair. So everything I say here is available on the internet or in PubMed, or if you just want to ask me. I do have a disclosure that I'm an advocate of allografts as a technique for cartilage repair. And I'm also an arthritis surgeon. So unlike the other people in this panel, I'm a joint replacement surgeon by training. So I look at cartilage repair coming from an arthritis background rather than a sports performance background. Cartilage repair is a super exciting field. I've been involved for 2 or 3 decades, and it's always evolving, and there's lots of things we can do better. Science, innovation, predictable clinical success, when I compare it to arthroplasty, is still elusive in a way. And trying to distill outcome, I guess the best way overall is my 75-25 rule. If you do the right thing 75% of the time, you'll get a satisfied patient. 25% of the time you won't. And that means there's a lot of reoperation in this world. The problem is with innovation, particularly in orthopedics, new treatments are adopted with little clinical validation, and that's hard for the casual cartilage surgeon to know what's right. And it's also expensive. And that's obviously an economic concern in this day and age. So what do you need to know about cartilage repair if you don't do it? The term cartilage repair has evolved to joint preservation. We're treating the organ, i.e. the synovial joint, rather than the lesion. So we look at background factors of the patient. We put them in categories, and we devise strategies that may include a lot of things and not just treatment of the lesion. That means that the surgeon has to have a bigger skill set or colleagues that help them, and be aware of technology and devices that are available or have supporting clinical data. And finally, you need to counsel the patient on what their expected outcome is. So cartilage is part of a biological system. That's the first scientific principle. So when you look, you remember medical school, or even you learned a little bit of this in residency, the previous 2 speakers talked a lot about the person and how they function. When you think of cartilage repair, you think about the tissue or the organ. And the take-home message for this is that the synovial joint, in cartilage repair, joint preservation, you need to think of the joint as an organ. And what is an organ? An organ is a group of tissues that have been adapted to perform a specific function. So in the knee joint, you've got cartilage, you've got bone, you've got ligaments, meniscus, synovium, soft tissue capsule, and the musculo-tendinous units around the joint. All of those are important. So the other principle about that is that you think of arthritis as a form of organ failure. And Bert alluded to this, showing the rise of arthritis in middle age. And when you see a cartilage injured patient, you have to understand that they have started, a process has been initiated in that organ for failure, a series of events that will lead to arthritis. And this is sort of a little model of what we call the arthritis cascade. And most of you understand the concept of post-traumatic arthritis, a periarticular fracture, but the new paradigm is soft tissue injury. Every ACL tear, every patellar dislocation with a cartilage injury, every meniscus tear, every cartilage injury starts a process. And the risk to these people of arthritis is anywhere from 8 to 15-fold higher if you've been injured rather than if you're not injured. And we're starting to get a handle on these things. And this is where biologics might help. There's been a session on biologics. And this is where we need better tools than our surgical skills. So the joint preservation concept. So we like to think of joint preservation as a series, as a group of things that we do, not just repairing the cartilage defect. That's an important part of it, but knowing how to repair or transplant, replace meniscus tissue, how to fine-tune the mechanical environment with osteotomy or other things like that. Ligament reconstruction, of course, as you just heard, stabilize the knee. And then, as I mentioned, biologics and disease modification are an evolving and important part of this preservation model. So if I look at where we were 20 years ago and where we are now, we would go to meetings and Bert, Seth, and I and Tim would say, well, how big is the lesion? And if the lesion was small, oh, microfracture or do an O. And if the lesion was big, oh, do an allograft or maybe an ACI. And that's what we did. So we all put everybody into buckets based on the lesion size. But that's a very outdated algorithm, and people should not be using that anymore in their analysis and evaluation of patients. We now talk mostly about background factors. We look at the patient, what's their personality and expectations, what's their neuromuscular status, as you saw in the last two talks, are they really capable of recovering to a high level? Obviously the alignment, and sometimes alignment is subtle and it's dynamic malalignment, not static. So of course, long alignment films, but everyone has to walk. And we're often doing osteotomies on people with very small dynamic abnormalities because a person, so an athlete, a lot of athletes are varus, some are valgus. That's physiologic for them until they have another injury. And when they do, that malalignment or dynamic malalignment becomes a pathological part of their condition. So it's a different mindset to think, oh, their other side's varus, so varus on this side's fine, not necessarily in the face of a cartilage injury. And, you know, we talked about the joint stability in the last talk, the ligament meniscus status. Personally, I'm not a huge fan of meniscus allograft transplantation, but that is getting a lot of play. And maybe Seth can talk about that. He did a great study that said that 65 or 68% reoperation rate, but that's part of the armamentarium. And then finally, the evolving thing is you look at the cartilage, but you really look at the subchondral bone under the cartilage to get an idea what the biology is going on in that lesion and around that lesion, part of that whole organ thing. So when you put that all together, you look at a patient, you put them in a box. You can either take their diagnosis or you look at the complexity or the burden of disease. And Tom Mine has popularized this with his ACI data, simple patient, the single simple lesion, nothing going on, complex or salvage. Unfortunately, most cartilage patients that come to us in referral are in the complex or salvage situation, which makes it harder to hit a home run. But often these patients can be the most grateful because they're pretty poor and you get them a little bit better or modestly better and they're happy, but they're not, you know, professional athlete level. So what is the ideal candidate for cartilage repair? Well, in my practice, it would be someone under 30 with few previous surgeries, an isolated femur or trochlea lesion, and this sound mechanical environment. And this idea of the biologically quiet joint, no effusion, synovium isn't activated, they're not starting this cascade of events, and they really don't want to play in the NFL. They want to just be a regular person and recreation, and they really don't have genetic risk factors, and that's part of that arthritis cascade. And there really aren't that many of these people, but when you see them and they really have symptoms that warrant cartilage repair, they're really good outcome. My failure rate in this group of people is 4%, which is competitive with hip replacement or any of the really good outcome surgeries that I do. So let's talk about strategies now. I'm not going to make a list of all the different techniques you can use, but I want you to think about them in a couple of buckets, the cell-based treatments and the tissue-based treatments. So the cell-based treatments, you're trying to get these cells to make chondral tissue in situ. The obvious traditional one, marrow stimulation. There's a whole slew of things called augmented microfracture now, where you add something like PRP to the mix or put a scaffold on it. ACI has become MACI, where you put the cells on a scaffold. That's popular because it's technically easier. There's a lot of minced tissue, which is probably cell-based, but there is whole tissue in that. Other cell sources, people are using BMAC, anything to put into a lesion to try to get it to grow cartilage. And then people are talking about empty scaffolds or scaffolds that are just structural scaffolds for blood or any other cell to grow into that. On the other side of things, tissue-based, you're restoring the tissue with restoring the defect with mature tissue. The autograft, the osteochondral autograft, the allograft, and you'll see on the market a lot of processed or minimally manipulated chondral or osteochondral tissue grafts. These are pieces of allograft tissue that have been processed that you just basically patch in the defect. And you know, what's out there has a lot to do with regulatory environment and a little to do what people are comfortable doing. This busy slide really shows the market, and still, in spite of all these complicated things, the vast majority of people that are getting cartilage surgeries are getting chondroplasty and still microfracture. Allograft procedures are increasing because of availability of tissue and these processed grafts, and the ACI procedures are going down, maybe because of cost and alternatives. So the point I'm making about the techniques, they're out there, but why are they out there? Because they work? No, the historical ones like ACI, allografts, we know they work. The ones that are out there because those that are developing have a low bar in a regulatory pathway that is a minimally manipulated tissue, not because they're clinically better, but it's easy to take a piece of allograft tissue and it's regulated differently as a minimally manipulated graft versus a cell-based treatment. And to bring a cell-based treatment to market again, like an ACI, is probably $40 to $100 million, and there's just not enough money in it for most people. So no one in the US is really developing complicated combination or cell-based products. So it's not about outcome, it's about cost to market. So let's talk about the surgeon. What do you need to be able to do if you're going to do allograft surgery or do cartilage repair or joint preservation? All of these techniques are useful and valuable. Honestly, I always think about what I'm good at, and I'm probably only good at 2 of these things, maybe 3. And I don't know if everyone's good at all of them, but maybe Seth is perhaps, or Bert, but that's a real important thing. Instead of thinking what's the right technique, what am I good at? Because execution matters. So the other thing that matters is staging procedures. So you see a patient, they need an osteotomy, they need a revision ACL, they may need a meniscus, they have a cartilage lesion. You can think of 10 procedures to do in this patient, but should you do them all together? That's not necessarily what you should think about in every one, to repair, replace every tissue that's got. So you start by taking off and hitting singles, right? So maybe do an osteotomy, revise the ACL, and then next time do an open arthrotomy procedure if you need it. And I just think that you're asking for trouble if you do a lot of individual procedures at once, because the accumulated adverse event rate is pretty high. We still do them, but I think this is a concept that you need to be aware of. The other take-home message I think is really important, and I think my colleagues will support this: microfracture is no free lunch. It used to be thought of as do it, no big deal. If it doesn't work, you can do something else. Number one, it delays getting the right surgery. It creates a potentially worse outcome for the next surgery. It creates a discouraged patient who doesn't want to go through a whole nother rehab. So the pendulum is moving back to first-line treatment, maybe a chondroplasty, evaluate, or if you really think the patient needs cartilage repair, you do the best option first, what you think is right, and whether that's a ACI, allograft, or something bigger than that, and not just fiddle around just because you're there and it's cheap. So what is the best diagnosis to treat in cartilage repair? Clearly osteochondritis dissecans. So if you're going to dabble in cartilage repair and you see a young person with a type 3 or 4 OCD lesion where you can't salvage the piece, fix that, and that will get you a really, really good outcome, predictable, and the patients will be quite happy. Our data and other data is really quite good. We have 90+% satisfaction, return to sport 75% or higher. So that's a great way to dabble or to start. If you see someone with OCD, fix it. If you think of the best candidates, like I said before, what is the outcome? Now I'm showing you data, my personal data in allografts, but I think this is translatable into ACI, the data, and those are probably the 2 mainstays with the biggest group of data, maybe OAT, but OAT is being used less now because the lesion size you can treat with an OAT is pretty small. So I think more and more of us are not using OAT to treat quote unquote incidental lesions. And once the lesion gets over 1 centimeter or 2, the idea of robbing Peter to pay Paul, we probably would prefer to go to an allograft or something with less potential morbidity. So in this setting, cartilage repair can be wildly popular, wildly successful, and 99% survivorship, 93% satisfaction, and a very important clinical improvement. But like I said, these patients are few and far between. I have 100 of these, and I have 800 or 1,000 patients in my total database, but only 100 of these patients. So sad but true. So what's the worst thing to do with cartilage repair? And there's a lot out there of people saying they can treat osteoarthritis with cartilage repair. And this is where you got to be careful, because you have a high complication rate and a high failure rate. Now, that may be okay to have a 50% success rate when you're salvaging someone at 22 years old and half of them you can get 15 years outcome, but it's not okay to do this in people that have a reasonable other procedure that they can do at 40 or 50 years old. So it's really important not to think cartilage repair, because patients believe this. They believe that you can fix their arthritis with cartilage repair or joint preservation. It's just not true. So if you put that all together, what are the risk factors? Age, younger the better. Diagnosis, I didn't talk much about this, but the traumatic, acute things, traumatic lesions, OCD, much better. There's certain areas in fractures and AVN where cartilage repair is useful, and osteoarthritis, be very careful. Anatomic location, apologies to Seth, but patellas are challenging. He knows this. 2 or more locations are challenging, but again, most people have more than one lesion. And then size of lesion, that's self-evident. The bigger the lesion, the more less likely you get a good long-term outcome. So I'm going to finish by just mentioning one thing that Seth said. You know, the typical care path of injured knees is really this sort of palliation cycle. They might see primary care, might see a rheumatologist, they might see an orthopedist that isn't a specialist, and that's okay. But these people don't necessarily always have the tools. They'll do the scope, remove tissue, and then start this palliation cycle. I really want to make a point that, you know, young injured person with cartilage damage, if you want to take it on, great. But if not, just it might be in their best interest to put them in front of someone who is really interested in cartilage repair to see if there's a restorative procedure that might change the natural history. And we're always here to help you, but I'm happy to answer emails and calls, but I really think young people with cartilage injuries need to have at least a talk about what is possible and what isn't. So with that, I'll end my talk. Thanks very much.
Thank you, Bill. And again, in our time remaining, what I wanted to do is conclude the fact that our aim today is the knee. The knee, looking at today's problems with tomorrow's solutions. And we've had 3 of the world's experts, patellofemoral joint, ACL, and cartilage repair and arthritis. And again, at this point, we've learned a tremendous amount. But let's have a few questions answered at this point. I'll start with really Bill. At this point, we have someone who's torn their ACL. They're a young person. We want to keep their cartilage. The joint is filled with cytokines. What are we going to do at that point? From your vantage point, I know you're not an ACL surgeon, but do we take the cytokines out? Do we use something that we can make a difference? What do we do?
Well, I think that you hit the nail on the head. We sit there passively when we see an injured joint and wait, and we should maybe do something active. I know you're going to say, you know, the idea of removing the blood, because blood has a lot of catabolic things in it, but what do you put in? I don't know, you put blood, PRP in. I think that's the holy grail. If we have these biologics, and you tell me what you guys do, I think sitting around and telling them to rehab the knee for a month until you come back for your reconstruction is almost seems old school now when we can think of things, but I don't think there's enough data to know exactly what to do. But I think at a minimum, remove the blood. What do you think? What do you do?
Hey, Seth. So, Seth, tell us about Chris Lauderman's work and how do we approach this?
Yeah, I mean, I think, you know, certainly for me, aggressive hemarthrosis removal is important to get good quad activation and pre-rehabilitation, all critical before going to surgery. Christian Latterman at Brigham and Women's advocates for, you know, intra-articular cortisone injection to reduce the inflammatory burden before surgery. You know, I have not been quick to embrace this, although it's intriguing. And I do worry about, you know, some of the cross correlation studies of going in, in risk of infection or other tissue healing, et cetera. So I think we take it with a grain of salt. I think maybe pivoting towards a biologic is not unreasonable. Just we need to know which biologic and if it actually works. So it needs to be done thoughtfully in a study, like a leukopore PRP, for example. Seems like a safer, more natural approach to me. Maybe Tim can comment.
Yeah, I have not been aggressive with early aspiration. I think that if you get the hands on them quickly, you can get, we don't have to wait the 3 weeks we used to wait. You can get them ready within a week or two. But I'm listening, and I think that it is understandable that there may be some options in the future that can help expedite this and with early aspiration.
Bert, is there any opportunity to take the hemarthrosis and get good factors out of it and put it back in? I mean, I know that that's been talked about. I've not seen that actionable.
It's a work in progress right now. And, one of the challenges, we treat everything in a binary way, but I really think there's this population that all of us see, that 45 to 55-year-old ski injury from Mammoth or Tahoe comes down. They're going to be a challenge. You're reticent whether you're going to operate or not. Those ones I've aspirated. I've used PRP. I've used cortisone. And in the cortisone group, I really feel that we can make a difference, especially in that group that has difficulty getting the range of motion early and is more sore, and you're putting them off. No question, as Tim said, we can get the young ones in there quickly, but it's really the middle age that is more challenging for us. Wouldn't everybody agree?
I just want to make one key point about cortisone. We looked at Kenalog being the least chondrotoxic, and I think most of us would agree that the local anesthetics are quite toxic in the joint, especially lidocaine. Ropey may be better. Dilute bupivacaine is in the middle. So avoiding the locals and considering Kenalog would be my.
Seth, that's a good point for the audience. The take-home message: no one should be injecting lidocaine in synovial joints anymore, right?
Narrapin is the best way to go. The Pittsburgh group and Connie has really addressed this. So overall, don't use Marcaine or lidocaine in the joint for long periods of time. Narrapin is the best one to use at this point based on chondrotoxicity.
I'm sure it's expensive.
Well, we have, and it's expensive. Yes, it is. I have one other question here in terms of allografts and cell survival. Bill, tell us about that. We have concerns in relationship to days and survivability and everything else. Billy?
Yeah, so that question came up in the chat. So I went through it pretty quick because I didn't want to deep dive into all the techniques, but fresh allografts have living cells. Even though they're stored for up to 28 days, there's 70% or more survivorship. And in retrieval studies, those cells are alive for decades. That means the matrix is supported by the cells and stable. So that's probably the best restorative procedure you can do. The process grafts, maybe not so much. They may not have any cells, and they may be a biomechanically competent inert scaffold. So it's really the nuance of what an allograft is not an allograft. So I said the fresh allograft versus process. And that's what you need to know, because you'll see these products, they'll be off the shelf and you say, wait, that's way easier than trying to get a fresh allograft. But in my book, there's nothing better than that. And for you cell-based people, the Macy, there's all sorts of, there's only one product you can use for cell-based, really. So there's not a lot of thinking in that regard.
Thank you, Bill. Thank you, Seth. Thank you, Tim. Leslie, you asked us, gave us an hour to talk about some of the new problems of the knee, and we've done it. We've learned a lot, and we'll move on. So thank you for having us.